Hi, I'm Dr. Abhishek Badrana, talking about algorithm for diagnosing common oral mucosal and intraosseous jaw lesions. I am a general practitioner and own a dental clinic in Rajajinagar, Bengaluru from 2014. I am also a founder director of 91 Danta Research and Product Development, where we develop products. Currently, we are improving DAB, dental aerosol blocker, in IASC, where we are incubated. I also provide oral pathology biopsy reporting services through Dr. Badrana's oral pathology and oral D histopathology services. I am also the General Secretary of POPMA, Practicing Oral Pathology and Microbiology Association. I would like to remember the most passionate pathologist I know of, Dr. Anita M. Borges, who has left such a mark on most of the students who attend her lectures. I keep quoting her wherever I go to lecture. What is common is more common than you think. What is rare is even more rare than you think. So she wants to tell us that the things that are said common in our textbooks is even more common when you start practicing. And the things that are rare, you have to be really careful before signing those reports. This lecture is dedicated to her legacy. What is common? Common from the Dictionary of Collins, it means it is found in large numbers or it happens often. Common lesion in private oral pathology practice. Simply what I did, I audited the cases that we received from January 2025 till September 2025. Totally, we got around 237 cases where 128 came within the jaw, that is the intraosseous one, and 109 of them were mucosal or soft tissue lesions. In intraosseous lesions, there were 29 different diagnoses that we gave it. Among them, the most common were periapical granuloma and radicular cyst, highlighting that the reactive lesions are more common than the neoplastic ones, and followed by dentigerous cyst and OKC, which are the developmental odontogenic cyst. Then we have the solid odontogenic tumor, ameloblastoma, which is the most common among the rest of the tumors in India. Then we had around 5 cases of unicystic ameloblastoma. There were 3 cases where we could not come to a conclusion, where we asked for more tissue. There were also 2 central odontogenic fibromas, 2 central giant cell granulomas, which turned out to be Brown's tumor, and also 2 fibrous dysplasia. So there are plethora of diagnoses that you can come across here. Similarly, in mucosal and soft tissue lesions, there were 36 different diagnoses that we gave out. In that, again, the reactive ones are most common: irritation fibroma, mucocele, pyogenic granuloma, frictional keratosis, healing pyogenic granuloma, closely followed up by the oral lichen planus, which is nothing but the autoimmune or lesion that is commonly noted in the oral cavity. And oral squamous cell carcinoma was closely followed over there. We had only 5 cases of leukoplakia and 4 cases of early invasive squamous cell carcinoma. It is really sad that leukoplakia is lesser than oral squamous cell carcinoma. It only highlights that the number of biopsied potentially malignant disorders are quite less, where patients do not come with the chief complaint of leukoplakia by themselves. Coming to the second word, algorithm. Most probably algorithms are the ones that are used in currently the artificial intelligence or machine learning, where are multiple algorithms are set for something to be recognized. Where does this algorithm happen? In their CPU. Our CPU is in our mind, where we need to follow the step-by-step process to solve a problem. What is the problem of a pathologist? It is diagnosis. Okay. Diagnosis is approached clinically, radiologically, biochemically. Then when you're grossing this one, you're going to look for some clues: histopathology, immunohistochemistry, as well as molecular. Finally, when you give a diagnosis, all these have to connect the dots and you have to give your diagnosis, right? I would like to share a story of how the penicillin was discovered. Sir Alexander Fleming went for a holiday and he felt that keeping the petri dishes on the table of the lab would be little dangerous. So let me keep it at a higher level. He put it close to the attic and he left for his trip. Because it was raining and the whole environment was moist, once he came back, the petri dishes had got mold. Completely, it was spoiled. If any other lesser scientist was there, he would have thrown it out, saying that my petri dishes got spoiled. But Sir Alexander Fleming, being the researcher and the bacteriologist that he is, he saw why his staphylococcus has not grown in certain areas. There was an area of restriction, zone of restriction. Then he thought, this mold that has grown is actually restricting the Staphylococcus aureus from dividing. Then he extracted penicillin from that penicillinum molds. And that is how an antibiotic was discovered. And from that time, the era of antibiotics started. So there are two important things that we have to know because of this discovery. One is serendipity of time, and second one is astute observation. Okay. Serendipity of time is the chance finding that puts you in benefit. You will only gain the benefit if you know how to apply. And astute observation, this is something can be learned. You can be more careful with everything that you see clinically as well as histopathologically. Attention to detail. Cannot underline the importance of history taking and cannot underline the important steps from the chief complaint. As I said, in leukoplakias, rarely patients came. 85% of it was a chance finding. Whenever there is burning sensation and you have an ulcer and you have an ulcer proliferative lesion, most of the times you're looking at especially if they have a positive tobacco history, it could be squamous cell carcinoma. History of presenting illness, if something grows very rapidly, it could be malignant or it could be a reactive lesion. We had a case this year called nodular fasciitis, which in 15 days of trauma became a lesion, which can also show that reactive lesions are even faster than the malignant ones. General medical history, this makes me go back to a case where I could diagnose a case of methotrexate induced ulceration in the oral cavity. The patient had gone to many dentists. All of them had put her on steroid ointments and so many multivitamins and some aloe vera gels and all. But when we took a medical history, she had rheumatoid arthritis for which she was given methotrexate. Just stopping the drug solved her problem. So that's very important stage that we have to do. Personal history, oral hygiene status, severe aberrations because of oral serous brushings and tobacco, alcohol, positive history can make us think about the mucosal health, dental history, where there was a trauma, there was a filling, and there was a history of root canal treatment can give you diagnosis, some intraosseous lesions, general physical examination, some amount of issues like the gait and the quality of hair. You can know the nutritional status of the patient. Oral examination. Most of the times, general dentist, especially I'm telling you UGs, you stick to hard tissue examination and you forget the soft tissue examination part. In terms of leukoplakia, they don't complain sometimes. So you not checking soft tissues, and especially people who are consuming tobacco, is doing a big disservice to them. Check the soft tissues. That's your buccal mucosa, tongue, ventral aspect, dorsal aspect. Then come to a provisional diagnosis. This is nothing but the algorithm. This is nothing but the step-by-step process where we come to our diagnosis. So I would like to remember another great legend who is no more with us, Professor Dhanasundaram, who taught oral medicine in government college as well as in Savita. Savita used to organize big UG oral medicine conferences where I was instantly attracted to oral medicine. I used to feel it's like magic. You can find out so many things through oral medicine. I used to feel. So that time, this was a story narrated by one of my seniors who was doing post-graduation in my undergraduate college in Vakaligarasanga Dental College, VS Dental College. He told that sir was so like obsessed with the subject and diagnosis that one of the ladies had come and she had a proper erythroplakic lesion mixed speckled leukoplakia where sir said, strongly felt that the person was smoking or there was tobacco use. And the patient said they never used this in their lifetime. Then he actually followed the patient for 5 to 10 minutes. And when the lady lit up for a PD, then he said, I knew it. And he went back. So that's how you're connecting the dots to get to your diagnosis. That's how the brain should work. This always remember. I remember because of people like him who are obsessed and eccentric towards this subject made a lot of difference in many people's life. After provisional diagnosis, you had radiology, IUP or X-ray. Intraoral periapical X-rays are often underrated, but this can give you a lot of information, especially in periapical radio opacities. You can actually trace the periodontal ligament space and continuous lamina dura. When the lamina dura is continuous, that could not be a cementoblastoma, right? It is connected with the roots of the teeth most of the times. Then it can't be something like a sclerosing osteitis locally because the tooth is vital, the periapical area is intact. Okay, the periapical area is not intact in such lesions. Chronic pulpitis can and periapical infection can lead to sclerosing changes at the periapical region. And this one is continuous. You should think of periapical cementoosseous dysplasia, right? And the best way to appreciate the ground glass appearance, it is in the IOPA whenever you're looking at fibrous dysplasia. Then on dental OPG X-ray, most of the times what happens now, people jump to CBCTs. CBCTs are done locally where certain quadrant is targeted, but you need the normal quadrant also. That is how you check the normal part of the jaw, right? So before jumping to CBCT, get always an OPG done where you have light and reft where you can compare and contrast. Then you have your beautiful CBCT where you can appreciate the multilocularity even more better. You can just see the septae looking at how the growth of a cyst or a tumor occurs. Then ultrasound for soft tissue lesions. Then you have your MRI, CT, and PET, which can give more informations. With this, you can give your radiological diagnosis. With this, you can come to few of your diagnosis and say this could be this, especially the tooth when it is associated with the radiolucency, we can think of odontogenic lesions. When it is not there, you can think of something else. So coming to cases where I feel the cases are the things that you'll always learn, and stories always stick. That's the story of Anita Madam. That's the story of Gnanasundaram sir, and that's the story of Alexander Fleming, where I said astute observation is important. So this is also a story that I would like to share. Two chief complaints where there is this pain that is there on the left side of the tooth of the area, slight pain and slight swelling on both the patients. First patient is a 22-year-old female patient, on and off pain, mild swelling, slowly increased to the present size, the swelling. Whereas second patient is 60-year-old female patient with slight pain, swelling has increased to the present size. Medical, personal, and general physical examination, they're nothing significant. In her case, there was a history of surgery of spine where the histopathology was inconclusive. They said there would be some atypical cells and patient had forgotten about it once he had come to the OPD for this particular problem. Oral examination, you could appreciate 3-6 root stumps noted with swelling associated in the region. Here, 3-6 was missing, 3-7 was filled, and 3-8 was no abnormalities, but the swelling was associated with the same tooth. Coming to the radiograph, both were associated in the jaw and they were sort of periapical radiolucencies. What should you see when you ask for an X-ray? You see that what is the condition of the associated tooth. If it is in the periapical lesion, how is the tooth? If there is dental caries, if there is a root stump over there, like in the case of case 1, there is a fracture, the diagnosis, you're thinking in a different direction. If there is cortical plate expansion, single cortical plate expansion, you have your dentigerous cyst over there. bicortical plate expansions. There are two different set of lesions. One is a fibrous dysplasia, shows bicortical plate expansion. One is ameloblastoma. You see, bicortical plate expansion. And sometimes there is no expansion at all, antero-posterior split. Then you can think of odontogenic keratocyst. Okay, what about resorption of adjacent teeth? Okay, so in periapical lesions, if these things occur along with the other lesions, you can think of it. Corticated margins, if there is well corticated, and it's a slowly growing lesion. If it is the cortication is not there, it means it is growing a little faster. So the bone is not able to deposit that calcium or to increase or to restrict the growth of that tumor. The remodeling is not occurring. The expansion of tumor is faster than the remodeling that can be noted. Generally, in odontogenic cysts, you see corticated margins. Then moth-eaten appearance or even margins also should be said. Is the radiolucency crossing the midline? Most of the times, OKC, you see that crossing the midline that happens. Here, case 1, you have a proper root stump and it's proper corticated margin and there is a radiolucence. Case 2, 8 is there and it is completely like cortication is not there, okay, and it's a fast growing tumor. There could be some sinister there. Provisional diagnosis would be a radicular cyst here. Provisional diagnosis is primary malignancy or metastatic lesion because of the growth that is happening here. See the case 2, the cortical plates are missing. It's almost getting destroyed. It means it's a really fast-paced growing tumor. Case 1, this was the gross, which was in multiple bits, and we could appreciate the non-keratinized cystic lining, and it showed proper scalloping in some areas, these areas. So this is a straightforward radicular cyst, case 1. Case 2, this was the biopsy that they had given us, and it was sheets and sheets of these cells, which were round and prominent nucleoli in areas, and in some areas it was eccentric placed, and you had some cartwheel appearance. We thought of two diagnoses. One is a plasmacytoma, and another one is your large B cell tumor. When we see anti-CD20, it was diffusely positive, and anti-CD138, that was also diffusely strongly positive. Then we did light chain restriction, where anti-lambda stains were completely strongly positive, and anti-kappa were negative, and focally they were positive in some areas. This means it is a clonal proliferation of a certain particular cells which is secreting one type of protein, lambda, that is your light chain in plasmacytoma. So again, remember, neoplasm is a clonal proliferation. This is one of a favorite definition of MAM. And as lymphomas, we are also learning there is polyclonal also. But for basic stuff, it is always monoclonal proliferation of individual cells. So case 2 turned out to be plasma cell neoplasm. But unfortunately, when they went back to the spine surgery, they found out that that also had some light chain restriction similar to this tumor. It turned out to be a multiple myeloma case. Okay. So case 1, as I said, it's a simple, straightforward radicular cyst in relation to 3-6. So what I want to say is the algorithm for diagnosing a common case, the algorithm for diagnosing a rare case is one and only. You follow the steps and you get to the diagnosis. I'm showing the difference because you need to see and appreciate the difference. Is so sometimes if the eyes are not trained, you feel everything is the same. Somebody can treat that as a periapical lesion. Okay, take it very lightly and do it, and maybe not submit to a biopsy also. Okay, that should not happen. You should know your subject. Medical history is important. Age of the patient, young girl, 60 years, and you see something like that, there is nothing wrong with the tooth. Be careful, always keep in your mind. And tell everyone histopathology is mandatory because sometimes a periapical lesion can be a sitting malignant lesion over there. Okay, you'll be doing a big service to the patient if you catch such lesions. Coming back to the chart here, I really like this, which actually shows the size of the box or the rectangle indicates the prevalence or the number of lesions. So we got a very common radicular cyst and we got a single multiple myeloma that we reported this year. So the algorithm was the same in catching both the lesions. So you go forward. If not histopathology, then you move forward for immunohistochemistry. Coming to the next set of problems, case 3 and case 4, pain in the posterior aspect of left side of lower jaw. This is a 48-year-old male patient who had on and off pain. There was mild swelling. This is a 34-year-old female patient. Difficulty to open the mouth and swelling has increased to the present size. Medical personnel and general physical examination were nothing significant in both the cases. Here, there was an impacted 3/8 with pericoronal tissue showing a little bit of hyperplasia. Tooth was not visible clinically, and there was mobility of 3/7 as well. Here, pericoronal area was inflamed. Tooth was also not visible clinically. Sort of similar cases, and you can appreciate the X-rays here. In case 3, you had an X-ray that engulfs the whole of the teeth and also goes up till the root apex of 3/7 as well. Here, the distal portion of 3/7 restriction is there. Then it goes to the neck of the tooth. So, whenever you come across pericoronal radiolucency, what are your astute observation? Cortical expansion, again I said single or both cortex. When both cortex are involved, think of ameloblastoma. When single cortex are involved, think of dentigerous cyst and think of odontogenic keratocyst at the later stages. Resorption of tooth root adjacent tooth. It means the ability of the lining is to resorb the roots. OKC pushes the roots and goes, whereas dentigerous cyst actually resorbs the roots. So have that, remember that. That is your observation. Corticated margins, slow growing odontogenic tumors, even ameloblastoma also is locally aggressive, but it takes time to grow. All of them have corticated margins. Okay, especially the cyst. Maybe ameloblastoma, especially the recurrent ones, will not have, but ameloblastoma compared to the neoplasms, cyst would definitely show the corticated margins. Are the margins regular, like how we saw the previous case, or irregular? Is the radiolucency distal to the third molar? This is one of the important things, is whenever you find a radiolucency behind the posterior most tooth, especially in the mandible, most of the times would be you are looking at an odontogenic keratocyst. Okay, look at this, you'll be really surprised to see the number of, again, if it crosses the midline, you're looking at OKC. So look at the radiolucency again, CBCT here. You have this margin restricted to one side. There is slight lingual cortical plate loss because of the swelling, but it is well corticated. It is associated with the neck of the tooth. Whereas here it is very, very destructive and the margins are uneven and it is really something else. We are looking at something else. This should give those clues. Case 3, I could see the epithelium lying freely in the connective tissue, showing a lot of atypia. It was really like scary or malignant. Okay, so what I did, I picked up the phone and called the surgeon. Sir, how was the surgical history? What do you feel? Do you want to share something? So the surgeon said that, doctor, I felt the tooth was floating in the tissue space over there. And I was removing so much of tissue. I curated, and I removed so much. I was scared where I'll go and reach the canal. And I definitely did not feel as if I'm working on a odontogenic lesion. It looked something else. It felt something else, is what I got a feedback from the surgeon. Okay, so based on the presence of an intraosseous component as well as the atypical features and freely lying islands of epithelium, we call this case as primary intraosseous carcinoma de novo. We didn't find a cyst, and continuously from there a malignant disease arising, we could not say, where we could say carcinoma X, odontogenic tumor or a cyst. We did not, we called it as a primary intraosseous carcinoma de novo. Okay, just look at the case. It's similar presentation. Case 4, a simple case where you had 3 to 5 layers of epithelium. It is non-keratinized, even though it showed features of corrugation, but we did not find keratin over here. So we called it a dentigerous cyst. So it was a step-by-step process where we could end up calling a dentigerous cyst, where extraction of tooth, enucleation sufficed. Case 3, they had to go back, do resection. Okay, again, our algorithm was the same, whether it was a rare or a common lesion. Take home message: whenever you are in doubt, you want to know more information, talk to the surgeon. I had once talked to the surgeon where the amount of tissue that I got was so very less. Okay, and it was a quite a good 2 into 2 centimeter, 1.5, 1.5 into centimeter cystic lesion. I called up the surgeon and I asked, what did you see inside the cystic lesion? Was it was empty completely. There was little bit of blood. They say something like that. Simple bone cyst is something that comes to your in your thought process, right? Right? It looks empty. The surgeon says looks empty. That is the description in Schaefer as well. So talking to a surgeon about the surgical history gives you a lot of information. And histopathology is mandatory for pericorneal radiolucency again. You didn't know how sinister that was, right? So this is a take-home message for all the undergraduates and the postgraduates. Go out and educate other branches of dentistry as well. See, we had 22 cases of dentigerous cyst, whereas 1 case of primary intraosseous squamous carcinoma. The algorithm was the same, right? Coming to the 5th case and the 6th case, 21-year-old male patient, ventral aspect of tongue, a small swelling which reduces and increases sometimes, and it is grown to the current size. This is a 52-year-old male patient. In the posterior palate, there is a bluish discoloration. Both of their complaints are that of bluish discoloration and swelling. And recently observed swelling, and can feel there is a slight bulge when he moves his tongue in his posterior palate. Medical history is nothing significant for case 5. Dental history, there is ongoing orthodontic treatment. Personal history and general physical examination, nothing significant. Just look at it. Ventral aspect of the tongue, there is some bluish swelling over there. Case 6, you have a bluish swelling on the posterior palate. It is close to the midline, but it's not crossing the midline. Okay, very rarely neoplasm of salivary gland origin cross the midline. This is case 5. Once I started grossing, there was some mucus that came out, and under histopathology, you could see this fibrous lining inside a eosinophilic material was there, mucin, as well as a lot of acute inflammatory cells, especially neutrophils, few eosinophils, and lot of mucinophages in the border. Okay, these were the inflammatory cells, and this is the eosinophilic material. Okay, this is a straightforward diagnosis of case 5, that is your mucocele. Whereas case 6, we grossed it and we got multiple cysts within it. In one area, we could see mucus cells, intermediate cells, as well as baseloid cells, epidermoid cells, and intermediate cells. We could see all the 3 kinds of cell, and that was such a small tumor in the posterior palate. That represented low-grade mucoepidermoid carcinoma. Okay, it is very difficult to take our fingers and make you look at individual features in the microscope. then assimilate that, and then give a diagnosis. This happens over a period of time. This you have to sit with the seniors who sit and diagnose. Okay, everything we can't teach. What happens in epidermoid cells is they look like squamous cells. These are your beautiful mucous cells, and these are your intermediate basaloid cells. So all the three cells seen, multiple cyst. You can see whenever there is multiple cystic area and you see a lot of mucous cells, you term it as low grade MEC. So here we could connect the dots, especially when we think of this lesion, right? In case 5, this boy used to run his lower tongue because of some irritation against his tooth often. Okay, that was the where trauma he got. Okay, that's where he felt this trauma, and that was becoming small, that was growing to some size. So we did educate him that that was the etiology. But here there is no etiology. The etiology has not been discussed for MEC. Okay, again, you can see 12 cases of mucosal, which was very common. The reactive lesions are quite common compared to the rest, and low grade of MEC. We had one case in this whole year. So I would like to reiterate the algorithm that I said for common lesions. It is also for the rare lesions. Whether it's rare or common, you need to be following your stepwise diagnosis. So whenever you see a white lesion, make sure it is scrapable or not. This is scrapable. This patient was on broad spectrum antibiotics for toothache, and she came back with burning tongue. I could scrape if this is your pseudomembranous candidiasis. Cracked mud appearance, very classic for homogeneous leukoplakia. Okay, you can't scrape it off. There is a positive history of tobacco usage. Okay. This one, Wickham striae, where you can see this lacy white thing coming out. This is like there are some red areas as well as these white areas. Okay. I had gone to Dandeli maybe like 6-7 years back, or I mean 4-5 years back, and I found this on a bark of a tree. And I was shocked. And because it resembled lichen planus, I could make out that this is lichen. Okay, it was a reverse thing what happened to Dr. Erasmus Wilson, who first discovered it, and he named it after this lichen. So just look at the borders, they are absolutely similar. So it is called lichen planus, my friends. Okay, so you narrow down to your diagnosis with a proper clinical history, look at all the features, record all the things that is necessary, then do your laboratory biochemical and radiological diagnosis, then your histopathology. Okay, have a format for taking the case history. This is the format that I follow in my clinic, which is really helpful. So the algorithm, chief complaint, from chief complaint, do all your examination, come to a provisional diagnosis, whether it's a mucosal disease or an intraosseous disease. Mucosal disease, whether it's a reactive, that is a irritational fibroma, mucosal or pyogenic granuloma. These were the most common ones. That is why it is in red. You make a decision to biopsy it and send it for histopathology. Neoplastic or autoimmune, the most common one is the oral lichen planus. And whenever you're biopsying vesiculobullous lesion, make sure you have your Michel's medium. Don't put it in formalin and send it for immunofluorescence testing. Okay, always remember that. Then your potentially malignant disorders, that is leukoplakia. Very rarely you're going to diagnose biopsy a oral submucous fibrosis unless there is a leukoplakic patch or there is an ulcer over it. Okay, and the different soft tissue tumors, the spindle cell tumors, which I spoke. He had one case of malignant peripheral nerve tumor in this particular mucosal disease. Intraosseous disease, we have periapical lesion. Again, it is in red because it's the most common one. Then the pericoronal one, which around the crown impacted tooth. Okay, most probably they belong to the group of odontogenic tumors and cysts, and the periapical ones, basically they're the inflammatory periapical lesions not associated with tooth. It could be a neoplastic disease or of different tissue origin or metastatic disease. So it is very difficult to label every common lesions and rare lesions. I made an attempt to encapsulate all this and give it to you so that you follow the algorithms and get it, whether you it's a common one or a rare one. You're going to reach there. You're going to reach your destination of your diagnosis. Again, I would like to highlight all these single ones. Okay, our very important diagnosis of primary intraosseous carcinoma, malignant peripheral nerve sheath tumor. We had a nevoid basal cell carcinoma syndrome and multiple myeloma case. There was a hypoparathyroidism jaw syndrome. All this, then you had an aspergillosis. Okay, these are rare cases, but if you follow the pattern of clinical, radiological, histopathological, you will reach the diagnosis. Okay, similar to mucosal. So we had a peripheral ameloblastoma, varicose hyperplasia. We had an oral erythroplakia this year, which is so very rare. It's a pure form. So teaching all these ones will take individual seminar on its own. My point to drive is whether common or rare, your algorithm should be there to diagnose this. Again, I would like to tell this, what is more common is more common than you think. What is rare is even more rare than you think. This was by Dr. Anita Borges. It is that shall stay in our memory forever. My gratitude to Dr. Bhuvan and the team of POPCON as well as POPMA. My guide, Dr. K.V. Narayan, through him only I could meet Dr. Anita Borges. She is the Dronacharya of Dronacharyas uh, who are there in India. So there are many ekalavas like me and you who keep practicing pathology. So she will stay in the memory, let her enthusiasm still infuse us and make us practice this pathology even more passionately. Then I'm thankful to my teachers, Dr. Sharda ma'am and Dr. Priya ma'am, who I have the opportunity to practice with. They are part of Dr. Badrana's oral pathology and orally histopathology services. I would like to sign off by saying that asking for help does not mean that we are weak or incompetent. It usually indicates an advanced level of honesty and intelligence, honesty to yourself and intelligent human being. If you're not able to come to a conclusion, ask your senior, ask the neighboring doctor, ask and collaborate. That's where you can solve the problem. Thank you very much. Have a nice day ahead.